Welcome, everyone. My name is Zach Miller with Landmark Ventures, host of the Social Innovation Summit. The Social Innovation Summit is a platform designed to elevate groundbreaking ideas and innovative leaders who are changing the world for the better. Throughout the year, at events both large and small, both physical and virtual, we are honored to partner with great organizations to amplify conversations and explore solutions to the biggest issues of the day. That's why we've teamed up with AARP to elevate the national dialogue around issues that impact longer and healthier lives for all communities. Next month, at our largest event of the year, our flagship annual summit, taking place virtually June 8th, 9th, and 10th, we'll welcome Edna Kane-Williams, AARP's Executive Vice President and Chief Diversity Officer, who is responsible for driving enterprise diversity, equity, and inclusion strategies for the workforce, workplace, and marketplace. She will be joining a blockbuster lineup of speakers to share their perspectives on social impact, from Dolores Huerta to Paris Hilton, Jerry Yang to Selena Gomez, Starbucks to Tesla. So if you haven't already, please register to see Edna and many, many more exciting speakers at socialinnovation.com. But today, we're very excited to continue our ongoing digital event series in partnership with AARP, featuring a solutions-focused dialogue on how we as individuals and as members of organizations and companies can address the key health equity issues that impact longevity, so that all of us, regardless of race, ethnicity, or income, can enjoy longer, healthier lives. We've sent to all attendees a digital brochure today with the agenda and bios of our speakers. And we're taking questions from the audience that our speakers will answer toward the end of the discussion. So please, we encourage you, submit your questions for our speakers through the Zoom Q&A function throughout the event. And now, without further ado, I am pleased to welcome our host and moderator for today's event, AARP's Director of Thought Leadership for Health, Dr. Irwin Tan.
Hi, thank you, Zach, very much for that wonderful introduction. I'm Dr. Irwin Tan, Director of Health at AARP's Thought Leadership team. And it's great to be back as part of our Build Equity series with the Social Innovation Summit and connect these three great panelists on highlighting solutions to key health equity questions and that impact longevity. It's been over a year now since the arrival of COVID-19 in the United States, and the experience has brought to light a number of inequities embedded in how we access healthcare and maintain the health of our communities. For far too long, systems designed and built to keep us all healthy have been piecemeal in their approach, not only in healthcare, but also in the intersection between health and other social supports like housing, healthy food, and education. As we slowly emerge from the pandemic and look to learn from our collective experiences, it's critical for leaders across public, private, and nonprofit sectors to reimagine what it means to support and contribute to longevity so all of us can enjoy longer, healthier lives. At the end of this program, we will preview a new collection of thought pieces released yesterday by AARP with experts from a wide variety of disciplines on how we might make longevity more equitable for all. I'm excited today to be joined by national leaders in public health who have significant experience working on these issues from a national, state, and local level. And finding actionable solutions to improve the health of the communities where we live is the topic of today. As we set on this journey together, I'm reminded of the remarks made by Dr. Martin Luther King at a press conference 55 years ago. Of all the forms of inequity, injustice in health is the most shocking and inhumane. So with that, I would like to invite our speakers to join us as I moderate this conversation. As Zach mentioned, their bios are part of the pamphlet, but and we've decided as a group to use our first names. We're all doctors here. But with that, I would like to, by alphabetical in alphabetical order, waiting for our speakers to join. Elena, do you want to go first?
So it's great to be here.
Introduce yourself, please.
Yes, I'm Dr. Elena Rios, President and CEO of the National Hispanic Medical Association here in Washington, D.C., and very honored to be a part of this discussion. I think for the NHMA, as we call it, we are a membership organization of Hispanic doctors, over 50,000 from across the country, who have grown up here, and we're probably the first generation of a critical mass of Hispanic doctors for this country. And as such, we've gone through lots of education from college to medical school to residency programs. But more importantly, we've been a part of the healthcare system, working inside hospitals to learn about patient care, also learning about patient care from our own families and our own communities, about what's needed to be asked and how can you help people talk about their symptoms, the issues of stress. And I think that that's most important about our organization, is that we have real life experience to develop solutions in our communities because we come from our communities. I come from the LA area. I grew up in Pico Rivera, California, went to high school in Montebello and Stanford undergrad, UCLA Medical School. And I just think that we have a wealth of knowledge to share today, and I look forward to building out the discussion.
Elena, thank you. Lydia?
Hi, everybody. I'm Lydia Isaac. I'm actually the incoming Vice President for Health, Equity, and Policy at the National Urban League. I actually start June 1st, so this is a little bit of a preview. So I'm very appreciative of being here. I've spent most of my career working in government and academia, thinking about issues of policy and health equity, and looking at how do we unsilo all the silos we have that deal with the social determinants of health. I'm really excited to join the National Urban League and think of, and using their theme of empowering communities to think about how we address health equity from a multi-level, multifactorial lens.
Thank you, Lydia. And Rishi?
Hi, Erwin and Elena and Lydia. It's an honor to join AARP and all of you today. I am excited for this conversation. My name is Rishi Manka. I'm a primary care and public health trained physician. I'm also CEO at Health Begins. We're a mission-driven national firm that works with health systems and with community partners to move upstream to help them to specifically to address the social and the structural drivers of health equity. Our belief fundamentally is that we need a radical transformation in the institutions and the systems that we operate in to be able to drive health equity. I know that I'm not alone in that belief, and a lot of our work is to accelerate that alongside our partners to achieve that mission.
Thank you, Rishi. And now we're going to start our conversation. We have some questions that I'm going to ask the speakers, but I also would like to invite the audience members to use the question and answer function to put questions in, and we'll be answering them towards the end. As we have said with some regularity throughout our series, health inequity did not arrive in the winter of 2020 with COVID-19. Based on your past work and experiences, what are some of the local, neighborhood level solutions you've seen successfully implemented to overcome these inequities, not only involving health, but also in housing and education? Who would like to go first?
I'll actually go first. I think we have to really think about how we use different factors and different sectors. So when I worked for, in New York City, I worked a lot in New York City, and I worked for the hospital system, and the public hospital system used, for example, the Medicaid redesign to think about how we transform buildings that maybe the hospital system had owned. We actually had some damage due to Hurricane Sandy, into housing for our most medically needed patients, so that they would be somewhere where they're stably housed, but also be close to the healthcare facilities they need. That is a way of thinking about how do we use policy and dollars that we already have to help people in factors that may not sound medical, but have a huge impact on how they're able to live their life and maintain a healthy state. And so having access to housing, therefore, allows people to not have to worry about that. And then, for example, if their medications need to be refrigerated, they have a refrigerator. If they need, if you're differently abled and need access to wheelchair access, you don't have to worry about, I can't get into my house because I don't have there's not a ramp. Thinking about those things for our populations that are most vulnerable are actually really important in order for them to be able to live independently, but also just healthy and vital lives.
Would anyone like to add to that?
Sure, I can add. I think the importance of our communities working together in the Latino community and other underserved communities, there's always been this important role for community-based organizations. And I'm not going to call any one type of organization out, whether they're education focused, job training focused. I think our communities have been very self-sustaining because people are in the same boat and need the help of others. You can't do it by yourself, or one family can't handle all the bills, rent, food, education supplies for their kids, right? Let alone computers and technology. And I think that the community-based organization concept in our society was always meant to be the support for a neighborhood. And also, I think that became the local church, that became the local school, parks, the places where people congregate have had visionaries throughout our society that have created places for people to have fun in the park, that kind of thing. We use the schools, for example, to get information to the parents about healthy lifestyle, nutrition. Now it's food. We actually have food programs that go through schools for whole families. And these are important ways that our society has developed. I'll leave it there as just a community-based effort. I think needs to understand that we have had visionaries use community-based groups, and that's the secret to our sustainability in poor communities.
May I kind of add into? Absolutely, a +1 to what Elena and Lydia just mentioned. And Erwin, I wanted to just maybe double click on the opening gambit of your question, which is that this issue of health inequity is not new. And I think we all 100% agree, of course, with that. And I really commend the report that the ARP has put out in calling out, I think in some sections, that this history is really fundamentally important to understand, and especially as we think about where we go from here. One of the things that I think is alluded to and mentioned, I think, in the report, and I know it's meaningful for the conversation of longevity, is a report that came out about 8 years ago now, by the National Academies of Medicine, now renamed. But the report was called the U.S. Health Disadvantage. And what the study authors had done in this comprehensive report that was like 400 plus pages was to compare indicators of health in the U.S. across all ages, races, income levels, to peers in other high-income countries. What they found was actually starting around 1980, there was a divergence, right? A divergence in terms of health outcomes between Americans, including, but not limited to, poor Americans, Black and brown Americans. There was but not limited to, right? They even found a divergence in health outcomes between white college-educated men, and how those Americans were also at a disadvantage in terms of health outcomes compared to peers in other countries. And so we have to ask ourselves, what was it that happened around 1980 that started to lead to this widening disadvantage in terms of American health equity and longevity compared to our peers? And this is true now across all ages, with the exception of towards the highest age range above 75. This is a powerful study that I think should give us pause. And when we look back at this, to your point about this not being a new phenomenon, what we can actually see is around 1980, we started to systematically underinvest or defund public health. 500,000 jobs on average in 1980, less than 200,000 jobs coming into the pandemic. In the last decade alone, about 38,000 jobs in public health and state and local departments were lost. The rise in social policies that led to, not surprisingly, the increase in the social and the structural drivers of health inequity. So we are not here by accident. And I think, to the point that Elena Lydia made, the neighborhood solutions that we're looking at are vitally important to invest in as we step back and look at that history that you so rightly kind of led us into this conversation with, Erwin. I think it's important for us to know where we've been, know what led us to this moment, so we can now start to understand where to go from here, both at the neighborhood level and, as Lydia rightly pointed out, at all levels.
And Rishi, when you compared the US to other countries, this past fall, ARP released the report working with IHME at the University of Washington, looking at life expectancy at age 50 at the county level from 1980 to 2014. And we saw a similar phenomenon of increased geographic disparities in life expectancy at age 50. And, and several other high-profile organizations have led a national dialogue on the link between where you live, your zip code, your county, and your life expectancy.
Right.
The number of you all and a number of guests in our series, we've asked about the challenges that originate with stark differences in longevity of over a few miles. What solutions do you see being tested and implemented that can help disrupt this life trajectory of those who grew up in a neighborhood or a town with poor health outcomes?
Well, I'm going to continue where I started, really was focusing on a community. So the solutions are in the community. And to Rishi's point about public health, I went to public health school. I actually studied health planning for small areas. And it was President Reagan, the governor of California, who became president. When I graduated from public health school, there went my career out the door, because he was the one who said, we don't need government getting involved in health planning. And the same law was the law that created the HMOs in our country. And the HMOs were allowed to flourish because they were private sector. And I think that part of our problem is that we don't necessarily see the importance of public-private partnership. And it does take all of us working together, taxpayers' money to give to government, to give back to our communities, to help our communities. Because when it comes to public health and infectious diseases, for example, that we're all involved with, this pandemic, everybody gets sick. It's not just the poor. So if the government can help with the public health issues, then the private sector needs to help also, but they can complement each other. And I think when it comes to the health equity problems that we have faced, we have a cycle of poverty in our country. And I think that's where we need to start. We really do need a minimum wage. We really do need families being able to have quality lifestyle instead of toxic stress, which means they're living in neighborhoods with drug dealers or drive-by shootings, or police that are shooting at anybody they see moving. I mean, and I shouldn't say that, but I mean, what I'm saying is that there's a lot of extra stress besides not being able to go to the doctor and till you're on your deathbed. Essential workers can't get out of work to go get the vaccinations because everybody wants to, do what they can to support their family and pay for rent and have food, the basic necessities. And there's just so much stress in our families that's why we see the rise of obesity and the rise of diabetes and cancers and heart disease, especially heart disease, that really happens in our young adults as they're starting their young families. So by the time they're in their 30s and 40s, we're going to see even more people on dialysis and having more healthcare issues. And, and that's why we don't see longevity in our communities. But I'll just say that I think that the solutions are to listen and to understand the stories of our families on the help that they really need with public-private partnerships.
I think I want to add to what Elena said about thinking about this issue. I like that you started off with the 80s, going back with what Rishi was saying, and thinking about this issue of what policies and actions we've put in place that have caused this. And so I think this idea of where someone lives impacting their health shows what we've done with things like zoning. How do we pay for education off of tax dollars? The policies we've put in place have actually set up a system of disadvantage for many people that no matter how hard they try, they can't get out of, because we have set structures in place that continue to disadvantage certain groups. And I think it's really important for us to think about the biases and the disadvantage and the barriers that are set up within our systems that don't allow communities, populations to access the resources and the tools that they need in order to lead a healthy life. And housing is one of them, how we zone neighborhoods, where we put, there's the whole NIMBY idea of not in my backyard. I'm not going to put a homeless shelter in my backyard, or I'm not going to put a low income housing in my backyard. We just saw with the past administration laws that prevented suburban certain areas from putting low income housing. When you do things like that, you embed in a structure and policies, and we've been doing it for 20 or 30 years, ways of segregating folks and limiting their access to the resources that they need in order to live the life they want to live. And I think that's really important for us to acknowledge that we have put barriers in place for children to get access to education, for adults, older adults to get access to healthcare, for young people to get jobs. All of that factors into why certain neighborhoods and certain areas continuously are having problems. And unless we as a community, a country, acknowledge that we have systematic biases in place, it's going to be really hard to bypass them.
Again, I find myself in the position of just taking notes and learning from Elena and Lydia. I think what you've unlocked for me is, and how my work and the work of my colleagues at Health Begins kind of connects to this is to this notion of, as you put it in the question, Erwin, of the national organizations now calling out zip code more than genetic code. I think we're seeing a rise in this understanding and these kinds of pithy kind of frames now for the past 10 years, and that's welcome, that's good. But one of the things that I think, and what Elena and Lydia just did for me, and I think for all of us, is to now interrogate, why is it that health outcomes differ by place? Well, it's because there have been policies and that have allocated or misallocated intentionally resources and power from certain places based on race and economic power. So what we're talking about now, and we frame this as the social and the structural drivers of health equity. It is impossible, and it perhaps can be injurious to have an analysis of health equity, of social determinants and zip code. It can be injurious actually to the cause, to the work, to the ultimate outcomes of longevity and equity that we care about, to have that conversation outside the context of an understanding of the social and the structural drivers of that inequity in the first place. So just a case in point, food insecurity, many people are talking about it. We've heard, on the housing side, that's one major social driver, but let's talk about food insecurity. Many healthcare organizations and many service organizations, many public health organizations are looking at how to improve food insecurity. It's time for us to actually start to recognize that food insecurity is an individual or household level manifestation of a sequelae of health inequities that are cascading from higher up. From higher up meaning food insecure individuals tend to live in food deserts. That's a social determinant of health, a community level phenomenon. Right? As our public health friends have said, social determinants of health are community conditions, not these individual social needs. These are community conditions. Why is the food, then we have to interrogate again, why is that food desert there? Well, it's not by accident. It's not people choosing to say, you know what, I want to live in and create a food desert for my family. It defies logic, it defies humanity. In fact, the food desert is there is because of structural determinants of health equity, as Kamara Jones and many others, including Elena and Lydia, have so rightly kind of pointed out, right? The structural drivers include structural racism, manifest in the form of redlining and both historic and modern versions of it, so that you determine which communities might be viable, quote unquote, for a supermarket or for access to healthy food. Right? The redlining, cascading down to food deserts, cascading down to the experience of food insecurity. That analysis now allows us to look at this phenomenon of inequity by place and understand it by the axis of race or racism, power, right, which is a thing we need to speak about implicitly, and also then policy. And I think what Lydia and Leah have talked about, the solutions therefore require us to be able to address the social and structural drivers at all levels, individual, institutional, and societal.
I like how you've all described about the personal experience of disparities, but then talked about the neighborhood and then the national drivers of this. And one thing you've all mentioned is this issue of economic disparities being linked with health disparities. That's been reflected in our previous conversations on this series. How are health and economic inequalities related, and what solutions can you see that can address both of them simultaneously, trying to think about solutions?
I'll give one, and that's the undocumented in our country. So in the Latino community, my grandparents came from Mexico after the Mexican Revolution. I mean, everybody's got family, for the Latino, for Asian especially. We've got a lot more people that are still undocumented, despite living here and paying taxes. And everywhere they go, they pay taxes, whether it's to buy something, sales taxes, or in restaurants, or even in the workplace. And people are here working under tax ID numbers. And some people get a green card and they're still undocumented in terms of not being a citizen. And in our country, we have ridiculous policies like you got to wait 5 years to get Medicaid if you're not a citizen. And even though you're, have a green card. I think that there are other policies like with the vaccinations, and I'll just use that as the example right now because we are talking about COVID-19 era pandemic, and vaccinations are free because the government is helping the major public health push, and they're under contract with FEMA and pharmacies and our community health centers to be able to provide the vaccinations to people that are eligible according to the states. They only have so many, so they've decided on eligibility by age and disease, et cetera. But I think what's important for people to know is that they are not supposed to be asking for government IDs and not supposed to be asking for healthcare insurance. And so many people in our communities are fearful of going to get a vaccination because they're afraid they're going to have to prove something they don't have. And they are also afraid of deportation. And so I see this as an example of how people that are marginalized, fearful, distrustful, because they lack citizenship. I think that's totally unfair. And I also think that what's going to happen is if they get COVID, how are they going to pay for, hospitalization and everything else? So there's a lot of issues involved with the undocumented, but I do think that as a community, as a society, we should take care of everybody and help with coming to terms with immigration reform that does have, a special way to handle healthcare crisis, such as the one that we're in. And I'd say one example of something that people have been talking about is perhaps an essential worker program, and start with that, because everybody realizes that you need supermarket people and you need gas station people, and our essential workers in our society have been recognized as being a lot of people that are Latino or Black or from poor communities, and they do need extra help.
Others?
Yeah, Lydia, do you want to go next?
I was going to let you go, Rishi.
I'm loving this. This is a great, I want to hang out longer. How long do we have here? Another half an hour? All right, let's keep it going. Let me just say, again, it's an honor to kind of be on this discussion because, this question itself of economic, the link between economic inequities and health inequities right now is a profound one. And Elena just laid it out in a few really wonderful ways. I think, let's remember, right, that by all measures over the past 50 years, the US Census data, for example, and many other measures have documented a summary increase in income inequality and economic inequity in the US, steadily. And it's been exacerbated, in history. And we've talked about the 80s and we've talked about other moments, but this is not just about one kind of era. This has been a continuous kind of, rise in inequity that's very closely linked to social and economic policy choices that have been made, both on the left and the right, by administrations, Democratic and Republican, to be quite honest. Now, that rise in income inequity, though, as it links to health, well, there's a landmark study that came out in 2016, Raj Chetty and colleagues, as many people reference, and it showed that, if you compare the life expectancy for the top 1% of income earners compared to the poorest 1% in the US, the gap in life expectancy among men was 15 years. Among women, it was 10 years. And to put that in perspective, if you smoke for your entire life, right, among women, that's the 10-year gap among women. a lifetime of smoking likely results in a 10-year gap. So the resulting kind of inequity or the drop in life expectancy from income inequity, right, is as powerful as a lifetime of smoking. Now, that should kind of give a chilling kind of feeling, right, for all of us right now. What does that mean in terms of what we need to invest more in, as Elena kind of pointed out, invest in the income protections, the labor protections, the social protections, right, for the poorest to decrease that inequity, but also not just invest in, but also divest from. And I really want to point this out because there have been a number of researchers around the world who have been long talking about not just the social determinants of health, but also the political and the commercial determinants of health. This is going to be our new frontier of work, at least where health begins, and I hope with ARP and our friends on the line here. Our new frontier has to be to interrogate, well, what do we need to stop doing, and not just what do we need to keep doing or do more of? What we need to stop doing, for example, are to support extractive policies or exploitative policies. For example, there's been a rise in the role of private equity firms, not just in mass incarceration and prisons in America, but increasingly in healthcare and in schools and other kind of sectors. And the science and the data and research tells us clearly that the incentives for private equity kind of ownership for and consolidation that occurs in many of the industries, including in healthcare, is directly linked to poor outcomes, poor quality, higher mortality. For example, in nursing homes, this is relevant for ARP. There is data that clearly shows that when nursing homes are bought by private equity firms, there is a commensurate drop in quality and actually an increase in mortality, right, that exists. These are extractive policies. I'm just using private equity as one example, but you can talk about healthcare institutions. In the midst of the pandemic, what we saw was more news reports about something that should give us all pause as clinicians, as social scientists, as political scientists, as a physician myself. What gave me pause was seeing hospital systems suing patients, right? Poorer patients on it more so than richer patients, suing patients at the time of after they go home. Can you imagine like the extractive nature of what that means when we understand the link as it is spelled out between economic inequity and life expectancy? It is as if we're violating the first principle of medicine, which is to do no harm. So we need to stop the extractive, exploitative, and injurious practices that are causing harm, and particularly causing harm by worsening economic inequity, right? As while we also start to invest in the protections and the policies we need to make sure that essential workers and the poorest among us right now don't have to wake up every morning thinking about whether their income is going to be tied to their life.
Lydia?
Yeah, and I want to build on Elena and Rishi's comments and thinking about not only the policies, but what folks who are in economic or having economic issues. Elena made a really good point in an earlier conversation thinking about toxic stress. And when we think about health over on the longevity, one of the things where, when we look at the Black maternal mortality rate, one of what we're seeing is this idea of weathering, which is Black women in particular have to deal with so much more toxic stress throughout their lifetime that when it comes time for them to be in their childbearing years, it has an impact on their ability to deliver a healthy baby and for them to live themselves, right? And so all of this pressure, this stress of economics impacting health from the beginning, it is exactly what Elena and Rishi talked about in terms of a direct link, but it's also this indirect link of always stressing about, can I pay my bills? Can I feed my children? Am I gonna afford to be able to go to school? And throughout a lifetime of stressing about those economic uncertainties leads to actually biological changes that impact folks' health. And I think that is what sometimes we forget to say, oh, well, I don't understand how somebody not having money is going to impact their health, but it causes a physiological response when you're stressing about your ability to pay a hospital bill when I had COVID because I don't have insurance. And going to Elena's point about, and also Erin, what you're talking about, one of the things, some people may call it low-hanging fruit. Some people may say it doesn't make that much difference, but we don't have universal healthcare in this country, right? So what Rishi was talking about exactly about somebody who was an essential worker, for example, who may be exposed to COVID because they had to go to the supermarket and take, and ring us up, all of us, and then doesn't have insurance and goes to the hospital and then gets sued by the hospital because they couldn't afford their treatment. That is a cascade of not only economics, but our health. We're not having a good health insurance safety net, and also toxic stress. And we have to see how all of those come together to impact the mortality and morbidity of our populations over time.
I think your comments about what we invest in and we don't invest in, and the issue of toxic stress weathering, and what institutions are best prepared to address those issues, has brought a question up from the audience. And this person asks, many people view public health as healthcare, as solely defined by access to a hospital. What do the panelists view as the key tenets of public health, and how do we expand the community's understanding of public health, as it relates to what we've just talked about?
I'm actually going to jump in here as the public health trained person, right? So actually, it's a funny point because there's two MDs and a public health trained person. And I even remember when I was going into public health, my family was like, what is that? Like, why are you just not being a doctor, right? They're like, go to medical school, which I understand. And I think this is a fantastic point, and I appreciate the person who brought it out, that public health, medicine is a part of public health, right? Public medicine is really important because it's our diagnosing and treatment function, right? But public health actually falls into this broader category of, we have medicine, which you diagnose and treat, but how do we prevent? What we want to do is not, what COVID shows us is that when we overwhelm our medical system, we have problems. And because we didn't use public health, which is prevention, right? Because public health really thinks about, how do I prevent things? So I know the masks were a really kind of flashpoint topic for people, but it's a fundamental, very small, easy public health measure to prevent transmission. When you prevent transmission, that means other people don't get it, and that means you don't have a bunch of people overwhelming the healthcare system. It is actually really that simple. And that is the role of public health, to help populations think about simple, sometimes complicated, but a lot of times simple methods to reduce transmission of disease, all sorts of disease. So one of the reasons why public health professionals are so about the social determinants of health is that now, if we move from infectious diseases, well, not in COVID, but before that, we had chronic diseases that were really overwhelming our country. How do we help people deal with and prevent chronic diseases? Access to parks, access to healthy food, access to housing, right? So all the things to prevent, so that you don't overwhelm the healthcare system, whose job is really to diagnose and treat. And I think that one of the things that we've been doing to the healthcare system is asking them to do something that is really not in their wheelhouse and above what they're capable of doing, because there's almost so much time an MD has with a patient in an office. And some of it is unfair. And what Rishi said early on in this conversation about, and Elena, about divesting in public health, we have then overwhelmed our healthcare system because we have not allowed ourselves to prevent these things from happening. And that is what public health does. Public health's mission is fundamental. The essential functions of public health is to help prevent disease. And then also to monitor, so that we can see ways that when diseases are coming, so that we can then try to get ahead of it. And we didn't do that during this crisis. As I joke with a friend of mine, we failed public health 101 and 102 and 201.
I think I'll just add, I went to public health school before I went to medical school, and saw the animosity between the two professions as a student. I think that what's important to realize is that public health came first. The whole idea of trying to, make people as comfortable as they could, with clean water and having, bathrooms inside houses, and I mean, all the things that have happened because of public health. Medicine, really didn't come into its own. I mean, we've had, of course, long time traditional medicines in all of our communities, but medicine really as a profession in the United States really hasn't come into its own until this last century. And I think that people forget that the real health stories of our society is really public health. And well, anyway, I could go on, but the Affordable Care Act, I'll just say that, had a huge public health infrastructure development section of the law that our government officials could not understand. And part of the problem we have is that the policymakers are not from the areas that they have jurisdiction over. So they're not expertise in and can't understand all the ramifications and consequences of what they do. And with the strike of a pen, they just got rid of public health that would have supported. So here we are now in a pandemic where people are now wondering, how are we going to build public health? That should be, and I think that is going to be the focus of post-pandemic world and longevity, is to have more public health programs, especially workforce health educators, those who work in communities. We call them community health workers. That's all about public health, and it is really important that we all realize too that a lot of the problems that we see in our diseases that we end up getting as we get older come from our lifestyles and our lack of food and good nutrition and lack of exercise and all that. And that really is about prevention and public health.
And Rishi, also in a previous conversation, you also talked about the need to fund more public health funding and the lack of public health funding. Did you want to add anything else to this?
Yeah, I think it just it's a good segue to, first of all, just plus one, as always. What was just mentioned, medicine only makes sense if it's put within a broader public health frame, and medicine therefore has not made sense because we haven't invested in the public health frame. When you don't invest in the foundations of the house, don't be surprised when it doesn't work in the way you intended. Medicine is just one room, right, in this bigger kind of house, this big foundation that we're trying to build as a country when it comes to health and health equity. I put in a link just to that end about some really welcoming news. Just this past year, a revised version of the essential public health services were released. And as you'll see, notably, it centers equity, which is a break from the previous version in 1994 that was first created. And you'll see, the 10 essential public health services, and to Lydia's point, medicine can play a role along with other sectors in helping to advance and support those essential public health services, but in that order, not the opposite, right? Public health is not there to serve the role of medicine, it's the opposite. And we do disservice. Now, to your point, Erwin, and what has been brought up, why are we in this situation? I think I saw something in the Q&A about the financing, question, and that's exactly right. There are financial, regulatory, and cultural reasons that we're in this predicament. The good news is for example, on the funding side that we mentioned earlier, like the chronic underinvestment in terms of staffing and resources for local and state public health departments. We saw what happened this past year in terms of the stranglehold that was put on the CDC, in fact, in terms of being able to react at the federal level, and we're paying the consequences. Lives have been lost because of what happened at the national level too. So the answer is to invest more. The American Rescue Plan that was just put forward now under the new administration has suggested putting $7.4 billion into correcting this problem. It's a really bold and necessary first step in correcting for this. About $3.5 billion of that goes directly to repairing the underinvestment in staffing. So $3.5 billion would go directly to hiring local and public health department staff, as I understand it. Another $3 billion would go to kind of modernizing and focusing public health on equity, with a specific focus on health departments at the state and local level in under-resourced, historically marginalized Black and brown communities, poor communities, rural communities. And so that's welcome news. To Elena's point, there's this builds on $250 million that was first kind of earmarked, and then there's additional $300 million and some other money coming out to help engage community-based organizations as well. And that's something that my colleagues and I, a lot of our partners, last year in May during the pandemic, we launched something called the Community-Based Workforce Alliance, a national alliance to be able to bring together the National Association of CHWs, for example, and Families USA and IHI and many others as part of this alliance, to elevate not just to recognize that a big enabler of the formal governmental public health workforce that we need to invest more in, as the American Rescue Plan now seeks to do. A big enabler of that is the ability to work alongside the community-based workforce. Note that I didn't mention necessarily the healthcare workforce, because I think that's already well funded. We just have to allocate and align resources better within the healthcare workforce. But
Well,
we need to invest more in public health and in community-based workforces. And that means CHWs. And that
Yeah.
means community-based organizations that employ and train them, right? And not just
Yeah.
hiring CHWs from the community into healthcare systems, but actually contracting with and building up community-based organizations. The welcome news about the American Rescue Plan, and I think what we're seeing now, hopefully, is the beginning of a shift, right? Is investing more in public health and more in the
Right.
community-based workforce that can help enable this. My hope is that this represents what happened actually, many times. I put a link into the chat for this question about income, and as Dr. Dave Chokshi, kind of, the New York City Health Commissioner, pointed out a few years ago, most of our public health advances have been because of what we've seen play out in terms of the poorest and the most vulnerable among us in history, right? The cholera outbreaks in New York City, for example, led to the rise of metropolitan health laws that then reformed sanitary conditions that benefited everybody. When we focus on, this is what it means to center in the margins, right? What it means to center with equity. When we focused on the needs, and we design a health system, a public health system, and a healthcare system that is there to actually be attuned to the needs of the most vulnerable, the most marginalized, and how to correct for that, it turns out not everybody benefits, right? And that's when we started to do in the U.S. since 1980s was to go in a different direction that clearly we're now paying the consequences for, right? We're seeing what's happening. This is an inflection point. The path to longevity and equity right now means in this moment, policy choices like investing in public health, investing in the community-based workforce allow us to actually make a departure, to have a different kind of trajectory, a different future in front of us. That's, I think, that's critical about this moment that excites me, frankly, in terms of our moment in this history.
Yeah, no, I think there's an opportunity in this moment that we cannot waste. And there's that urgency of now, as we described. I think we have maybe time for one more question. So I'm going to sort of assemble a few questions together, thinking about health from healthcare to public health, thinking about the individual, the neighborhood, the community, thinking about the issue of mistrust that has been elevated with the COVID-19. There's an unfortunate buildup of mistrust in several communities. How do leaders across public, private, and nonprofit sectors re-engage with communities and restart this dialogue around health? And are there specific examples that come to mind as we try to address this issue of mistrust at the individual and community level?
I think the first thing I want us to all say, because we've had a lot about mistrust, we've had a lot about African-American hesitancy for the vaccine, which we see actually there is some hesitancy, but there are actually other groups that have higher hesitancy, but we've been focusing on this group for some reason. And there is also, to me, a vein of it is unwarranted, right? Okay, so we had this one study, everybody wants to bring up the untreated study of syphilis in Black Americans. So that's actually the name of the study. It's not the Tuskegee study. If you read the actual study, that's the name of it, that the public, the US Public Health Service is the one who conducted. Everybody wants to say, okay, it was that study. They want to talk a little bit about Henrietta Lacks. I think what we have to acknowledge and people need to be fundamental about is that in many communities, people of color, indigenous communities, immigrant communities, rural communities, there has been a built-up of mistrust. It's not one particular incident. It is not one particular study. It is how people have been treated their whole life that makes them, and their family members. So even if they particularly haven't been treated bad in the healthcare system, family members have, and they've seen it. And this mistrust has been a build-up. And so we do a disservice when we just say, oh, it's Henrietta Lacks, or oh, it's the case of the Tuskegee study, and that's why people are vaccine hesitant. No, they've been mistreated by the healthcare system and public health. As a public health professional, I can say that throughout their history. And these systems acknowledging that we have not been transparent, we have not given full information, that at times we have done stuff that have hurt communities. It's really important for us to rebuild trust. And it's not just not doing bad things. So it's not just, as Rishi was saying, correcting the bad things that we've done. It's also transforming how we interact and how we partner with communities to rebuild the trust. And part of that is about the workforce, having a workforce that represents the communities that we're in, because people trust who they know and they trust their neighbor. One of the biggest things about vaccine hesitancy is knowing somebody who got the vaccine. it's happened in my own family, in my own life, where, you know, I had people who did not want to get it. And then I got the vaccine and nothing happened to me. And they were like, oh, maybe I should get it. And then I also explained to those family members and friends the history and how the vaccine came about and why I think it's safe and why I decided to take it. And I didn't push them. I didn't say you have to take it. I said, here's what I know from my expertise, and this is why I took it. And you make a decision for yourself that's best for you. Also, trusting people and not being paternalistic to make the best decision for themselves is actually really important. And that's the whole idea of mistrust. We have not done that to communities for a really long time.
Elena, Rishi?
I'll just say that I think I totally agree with what you're saying, and it is it's systemic racism, systemic discrimination in our society. Again, for the Hispanic community, women were sterilized in Los Angeles County Hospital, and as well as in Puerto Rico. I mean, there are just so many instances of mistrust of government, and a vaccination program is another government program, right? So there's just, and I think that for the Latino organizations that are really involved with getting the messages to our communities about how important it is to get vaccinated, it's about protecting your families. It's about protecting your communities. The vaccines are safe. They have been studied with people like us. They oversampled for once, you know, clinical studies oversampled minority people, and they are safe and effective. And it's much better to get a vaccine than to be in a hospital on a ventilator. I mean, we those are the kinds of messages that need to happen. But unfortunately, especially with Spanish media, there's been a lot of discrimination, not discrimination, a lot of myths. Oh, you know, your DNA is going to get changed. Oh, you're going to get killed if you get a vaccine. Oh, you're going to, oh, anyway, there's just so much problems. But one thing I wanted to get back to, just to mention the importance of workforce. So the National Hispanic Medical Association was created because we're the first critical mass of Hispanic doctors that were even allowed into the healthcare, into the education system in this country. So the education system needs to change to be able to have workforce that gets into not only public health, but I do think nurses, my mother was a nurse, nurses, doctors, pharmacists, they're all part of our community messaging system. They not only do all the technical and healing and all of that when people are sick, but they are also trusted messengers at the pharmacy, at the local clinic, at your doctor's office, at the dentist's office. And I do think that it is important to have role models in our communities of people that look like them. And unfortunately in this country, even though we've been around since the 1970s in terms of Hispanics getting into medical school and African Americans for critical mass, Native Americans, our country only has about 5% of the total doctors that are Black or Hispanic. And I mean, that's ridiculous, but and it hasn't changed. We've been flatlined all these years. And I think a few more get in, but a few graduate. So, you know, I think what we really need is more of a focus on health in grammar school and high school. And it is an industry that can't be outsourced. So it is a top industry for jobs. And I don't mean hospitals and clinics. I mean public health or pharmacies or all the different types of jobs that it takes to keep people healthy is important. And for us, we're very interested in the professions that where it takes longer to get in, and we do mentoring for college students. We give scholarships to those few Hispanic students that actually made it, and we have a coalition of groups called the Hispanic Health Professional Leadership Network, with doctors, dentists, nurses, mental health workers, social workers, dietitians, pharmacists, and health executives, hospital executives. We're all part of helping our institutions or agencies that we work at build programs for the community. So I think that's why it is important to think at all levels, not just, and I know, Rishi, you're talking about community health workers are important for the messenger at the local level, but I still think within our we're not going to change without becoming the leaders of those institutions. And that's what we're all about. So I just want to put that plug in there.
I 100% agree with that, Elena, and I really appreciate you rightly pointing out both the issue as well as the important work that NHMA has been doing, you know, at the vanguard of that. It's linked to trust, right? You know, trust is a function of who you can talk with and who you can connect with, both in healthcare and public health and community. And I just want to bring up just two other dimensions of it. One is just access. Clearly, the focus on vaccine access is more important because of the implications it has for policy and structure, and you know, just what we're doing in terms of making sure that that there's equitable access to the vaccine and access to information right about the vaccine to dispel the myths, and not so much about hesitancy, because I think the data tells us that actually the uptake and interest is actually is very high actually, and among Black and Brown communities relative to other Americans. Now, the other, besides access, I also just want to mention quickly accountability. What we have chronically shied away from, for perhaps obvious reasons, is the questions of accountability, and not just federal, kind of national accountability. How do we make sure that at the federal level, we're doing all we can to ensure that vaccine access and other issues of equity, that the strategies are implemented equitably? What's the accountability to make sure that happens well? But accountability at the institution level. There are actually well-defined components of institutional accountability that very few institutions are willing to actually engage into conversations about. And I think now in the past year, especially, we have an opportunity to actually take bold leaders in healthcare, in the social sector, and public health, and now actually commit to work with external stakeholders to increase accountability. What that means is more community-centered governance mechanisms, so that community is not just a beneficiary of services, but is involved in the oversight. That there's redress, not just federal reparations, for example, but in addition to that, questions of institutional redress for harms that have been done by specific institutions, right, for perpetuating inequities. Community-centered governance and redress. Second is transparency. You can't have health equity and not kind of share the data on it and not make that available for public scrutiny, including scrutiny by your community members who are most marginalized. Transparency, answerability, meaning, are you providing a rationale as an institution for your decisions or decisions not to do something? And is that available for scrutiny and oversight by community stakeholders? Compliance, are you actually doing the work? Are you going through the process right now? Do you have monitoring systems in place? And then lastly, consequences. What happens when there are shortfalls in outcomes or in processes, right? If you don't have community-centered governance, is it NIH gonna penalize a research institution? If you don't have transparency, is JCO going to hold a hospital system accountable? What happens if you don't have answerability, right? Does the AARP hold its membership affiliates responsible? So we need to increase accountability here, because accountability is a mechanism to build trust.
So I want to thank all of you for joining us here today, and I want to continue this conversation. These are powerful conversations that need to be heard, and we also have a new compendium that'll be coming out that Rishi, you're a part of, and I want to link people to arpinternational.org/longevity collection, where we can continue this conversation. And we're going to provide a preview to this content. But before I go, I want to say thank you to all, both the panelists and the audience, and please continue this conversation, and please continue to fight this urgent issue. Thank you.